All right, we're going to go ahead and get started. First order of business, are we up on the WebEx? Okay, great. First order of business is bill introductions. The chair will recognize Kyle Kessler because he tattooed bill introductions on his forehead for me today. Yeah, not really.
That was just banter, Madam Chair. Members of the committee, I'm Kyle Kessler, Executive Director of the Association.
Is that mic on?
Now it is.
Okay, thank you.
I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We appreciate the opportunity to appear before the committee this morning requesting introduction of Bill RS 0683, which would establish the 988 mental health crisis hotline. And this was one of the recommendations out of the Mental Health Modernization and Reform Committee.
All right. Scott, do you have that? I don't see Scott, so, okay.
I see Jenna.
All right, Jenna's got it.
RS 0683.
All right, thank you. Is that it?
That's it. Thank you.
Okay, thank you. Representative Epley.
Thank you, Madam Chair. Appreciate the opportunity. There are two bills that I would like to introduce today, and they are, the first is 21 RS 0888. Subject matter is lifting the cap on the irrevocable trust for pre-planned funerals. And then the next one, I'll see if there's pause for a moment, if there's any questions. I just know about the title. Okay, and the second one is 21 RS 0892. And again, this also is from the Funeral Home Directors Association. They would like this introduced as it relates to cremation certificates when people die either out of state or another domain and then come back to our state for processing on their cremains. So
I think Representative Barker has a question for you. Representative Epley.
I do. This is Health and Human Services, not the mortuary. Is that correct?
well, I think, sir, to answer your question, Madam Chair, if I may.
Yes, you may.
Thank you, Madam Chair. We cover the alpha and the omega, and this would definitely be the double omega.
But just one more question. On the first part, you're opening up the trust on as far as prepaid burials?
It's my understanding it's capped at $10,000 right now, and the desire is to open that up and not have a cap on it. And I don't know the specifics of the legislation yet, if they're going to raise it to a certain level or have it unlimited.
I have one more thing. I have a friend who's a mortician, runs a funeral home, and I always ask him how he can frown at a $10,000 funeral. Because I had a case one time, the markup at some of the services that they do are just phenomenal. But anyways, with that, I have no objections.
Representative Barker, the idea would be to make them even more amazing now. So thank you, Madam Chair.
All right, and I would imagine something that deals with a trust is probably going to better go to a financial institutions committee, because when you raise up a trust, I don't know, I'd have problems with that one. So, okay, committee, are there any further bill introductions? Representative Epley with a question.
Just on roll call today is Representative Berquist or Henderson, are they on? I can't see. I don't have my glasses on electronically.
Henderson's back there.
Oh, he slipped in on me. Okay.
Well, that's because he's always so quiet. We have to go looking for him every time.
And the only one unaccounted soul is Representative Berquist. Is he on electronically? Or is he just not here? I'm not trying to call him out, but I guess I am.
Yes, you are.
Okay, thank
you. He may be
you.
running late.
Thank you, Madam Chair.
All right, committee, if there's no further bill introductions, we're going to go ahead and open up the hearing on House Bill 2160. So do we have Scott Abbott on that, or do we have Jenna?
Thank you, Madam Chair. I will handle briefing House Bill 2160 for you all this afternoon. Good afternoon, committee. House Bill 2160 was sponsored by this committee, and this is the Certified Community Behavioral Health Clinics bill. This would establish a process for certifying and funding CCBHCs and giving certain powers and duties to the Kansas Department for Aging and Disability Services and the Department of Health and Environment in order to accomplish that goal. So the bill would require KDADs to establish the process for certification and funding for certified community behavioral health clinics. And certified community behavioral health clinics would include any community mental health center that is licensed by KDADs and provides a comprehensive list of services that you can review in the bill in subsection B on page 1. The bill would also require KDHE to establish a prospective payment system under the Medicaid program for funding these clinics. And this payment system would permit either daily or monthly rates. The bill would also direct KDHE to submit to the federal government any approval requests necessary, as is standard for anything Medicaid related that you all do by legislation. It would also direct KDHE and KDADs to have this system in place not later than July 1st of 2021. The bill would take effect upon publication in the Kansas Register to give them more time to begin that approval and implementation process. And with that, I would be happy to answer any questions the committee may have.
Committee, are there questions for Reviser Abbott? Representative Turner,
So,
is your mic on?
Well, it's the blue light's on. Does that
Okay,
work?
sometimes you almost have to eat some of these mics to
All
get
right.
them to
How
work.
about this?
Okay, thank you.
So, absent this, what's the current structure under which these facilities operate? What are we moving from and to with this bill? Is my question. Sorry. Thank you.
Sure.
Scott.
Thank you, Madam Chair. So these are currently community mental health centers. My understanding is that the certified community, I always get this acronym backwards. The CCBHC model is a federal Medicaid kind of funding mechanism. It's a designation that the federal government has for allowing them to receive funding through the Medicaid program. I'm sure some of the conferees can speak more to logistically how this may affect those centers, but ultimately it's kind of a designation by the federal government that this would simply allow the state of Kansas to take advantage of.
Yeah, Representative Turner, I think, Scott's right. Kyle Kessler, who'll be our first conferee up, I think will be able to go into a lot further detail. He lives and breathes this acronym that I've had to learn to pronounce because it's got one more letter than it should have. Thank you, federal government. Is there any further questions for Reviser Abbott? Thank you, Scott. I appreciate it. First up, I have Kyle Kessler, Executive Director of the CMHCs of Kansas. Welcome to committee.
Thank you, Madam Chair. Members of the committee, I'm still Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We appreciate very much the opportunity to appear here today in strong support of House Bill 2160. And as a reminder, we represent all licensed 26 community mental health centers around the state. So whether you live in Leawood, Kansas or Liberal, Kansas, there's a community mental health center that should be providing services in your area. We see this as a foundational piece of legislation to address the mental health and addiction crises that Kansans face with our current overdose and suicide epidemics that have only worsened due to COVID-19. I'll tell you that this bill seeks to create the certification process for CMHCs to ensure they are providing the 9 key services that I'll talk about a little bit in a few minutes. And for it being a short bill, it really includes 2 strong state agencies or large state agencies in the Kansas Department for Aging and Disability Services, which is designated as the state's behavioral health authority, and then Kansas Department for Health and Environment, which is the state's Medicaid agency. So it requires the collaboration between them in forming this venture. There are essentially 3 key parts to our testimony amidst all of the statistics and examples that underscore why this is essential legislation. 1 being policy and treatment, 2nd being funding, and the 3rd piece being reform. So under policy and treatment, I hit on the core services or the crisis services being one of those, and the other core services that are mentioned in the bill that are required to be provided by a CCBHC. Most, if not all of them, are being currently provided in our CMHC system. Those are crisis services, screening, assessment, and diagnosis, which includes risk assessment, person-centered treatment planning, outpatient mental health and substance use services, primary care screening and monitoring of key indicators and health risk, targeted case management, psychiatric rehabilitation services, peer support and family supports, and community-based mental health care for active duty military members and veterans. You'll hear a lot from other conferees through the course of this testimony or this hearing, that most of them being community mental health centers. One of them, Four County Mental Health Center, was recently given a CCBHC grant, or actually last year was. And as a spoiler alert, I will tell you, you'll probably hear a couple of them express their enthusiasm, as yesterday we were notified that 5 more CMHCs were given CCBHC grants. So that segues to the funding part of what I was going to mention in my testimony. Those of you who've worked with me know that I can sometimes be the king of policy wonkiness, or even sometimes oversimplifying things. And on this issue of funding, I want to try and oversimplify it, because some folks would say, okay, if there are these CCBHC grants coming out to your system, then why do we need to do anything with a prospective payment system with Medicaid? And what happened was, about 6 years ago, the Excellence in Mental Health Act was passed at the federal level. It was fantastic behavioral health legislation that was championed bipartisanly by Senator Blunt from Missouri, a Republican, and Senator Stabenow from Michigan, a Democrat. And it was in the aftermath of the Newtown shootings, and it created these outcome-based, service-oriented funding mechanisms where, when you have the prospective payment system and grants, so under the Excellence Act, grants were available to get the infrastructure up and going, and then the prospective payment system, which is essentially cost-based reimbursement, was put in place for sustainability. So those are the two pieces then that are part 2 and part 3. The federal government only allowed a certain number of states to enter under the Excellence in Mental Health Act. Originally it was 8, and then they added 2 more. So Kansas is currently shut out of that process, which would be the grants, and then also the prospective payment system, or cost-based reimbursement. What we've seen happen over the last 2 or 3 years, the previous federal administration, the Substance Abuse and Mental Health Services Administration under the U.S. Department of Health and Human Services, started putting out just the grants for folks who were, or organizations that were interested in providing the core services and becoming a larger part of the behavioral health system across the country, which would include services to veterans as a priority, suicide prevention, and crisis services are other examples that I mentioned under policy and treatment. So when they started putting out those grants, then there was the need to also then put in a sustainability function, which at the federal level, and that's what we're asking this committee to do with House Bill 2160, is allow us to set up a prospective payment system, which, again, this was one of the recommendations under the Mental Health Modernization and Reform Committee that met all last fall. So certainly Chairwoman Landwehr, Representative Lynn, Representative Bishop, and others were very involved in this. And so the prospective payment system is something that the state of Texas, their system, has embarked on, even though they were not an Excellence Act state initially. And so we had presentations over their system. And so to replicate something like what Texas is doing would be great. And so we're asking for a prospective payment system to be set up for the community mental health center system through the Medicaid agency, either through a state plan amendment to our Medicaid plan or an 1115 waiver. Those would be one of the 2 mechanisms. And then we would work with KDHE and KDADS to figure out what worked the best from an efficiency and timeliness standpoint. And so lastly, I would mention the reform pieces of my testimony. We've talked so much as a state about the need for criminal justice reform, and the amount of, and the Criminal Justice Reform Commission talked quite a bit about addiction issues and behavioral health issues in their work. And then you also add the presentation you all had last week over school-based mental health treatment, another area of reform. And we're doing that, and other states like Missouri are doing yeoman's work in what they're able to accomplish with school-based mental health services under the CCBHC model, and not just serving people in the 4 walls of the community mental health center. And lastly, one of the other things relating to reform relating to healthcare and behavioral healthcare, state of Missouri has also seen substantial reductions in emergency room visits and inpatient hospital admissions, and I think 20% and 36% respectively, although I may have those numbers switched around, I apologize. But if we could just get to half of that, the savings of hundreds of thousands of dollars or into the millions would be very achievable, I believe. So in conclusion, I would say to the committee that we are at a critical point in our state's history, and one in which we must make the decision to at least match the investments that are being made in behavioral health by states surrounding us. Both Missouri and Oklahoma were early adopters of the CCBHC model, and you'll hear from some of the other conferees after me about the recruiting that takes place across the state lines. I know across the hall, they're having conversations about the Promise Act right now relating to higher education, and I believe this House, this chamber passed that bill last year, and they're talking about adding behavioral health technicians to that. I believe it may be in the language now, but I heard last week about one of the CCBHCs in Missouri that called a community college in Northeast Kansas and said, hey, if you guys do that, let us know. We'll have internships lined up. So now they're already recruiting our community college students to Missouri as well. And I thought pretty soon they're going to start visiting Kansas high schools and junior highs if we don't try and keep up. So that was painful to hear, but I do have hope that maybe we can make some real investments and policy changes that will allow us not just to keep up, but exceed what they're doing, because we truly have the infrastructure in place. So in conclusion, I would just say that this is a system, I believe, that will serve well, not just our kids and grandkids, but the students they sit next to in school, who we've never seen, as well as our parents and grandparents and whoever they sit next to in church or whoever they might pass on the street. So with that, Madam Chair, I would stand for questions at the appropriate time, and that concludes my testimony.
All right, thank you. I think what we'll do is we'll get through all of our conferees, and then we'll open for questions.
Thank you, Madam Chair.
Thank you. Next, I have Steve Denny, Deputy Director of 4-County Mental Health, and I believe you're coming in via WebEx.
Yes, hello. Can you hear me?
I can hear you.
All right. Well, greetings from Southeast Kansas, and thank you, Madam Chair, for the opportunity to testify, and thank you, members of the committee. As introduced, my name is Steve Denny. I live in Southeast Kansas. I'm coming to you from Independence currently. I've worked in the field of behavioral health since 2002. I've worked in the Kansas mental health system since 2005. Lifelong Kansan and almost a lifelong Southeast Kansan for the most part. As Kyle mentioned, at 4-County Mental Health, we serve 5 counties: Montgomery, Cowley, Chautauqua, Elk, and Wilson counties. And we found a couple years ago that we were starting to lose talented, experienced employees to our neighbors in Oklahoma. So we started asking the question, what's going on next door to us? And we found out that our neighboring state in Oklahoma had adopted the CCBHC system. So fast forward to 2020, SAMHSA put out expansion grants, and it was an opportunity for us to apply and move towards being a CCBHC lookalike. And that's what we're doing now. We were the only organization in Kansas awarded a grant. And so we've been starting that process since May of last year. And I'm excited to hear that some of our partners are going to be on board with that soon. But what has happened essentially is we've been able to do 2 things. One, pay our staff at a more competitive level with our neighbors in Oklahoma. And it's been very important for us to be able to do that through this grant. But even more importantly is reform our organization to be prepared for the CCBHC system, because the writing on the wall is there. We believe this is the future of behavioral health in Kansas and nationally. Kyle did a good job of describing the kind of the backbone structure of the CCBHC in terms of services and what has to happen to be certified. And as he said, most of those things are incorporated into into a CMHC in Kansas. So all of the 26 community mental health centers provide most of the services that are required. But what does it change? What does it look like? That was a question earlier. How does that impact what we do differently? I would say there's really three things that happen. One is you have to become more comprehensive. So not just focusing on behavioral health, We also think about physical health, and we screen for conditions and issues that need attention. We become data-driven, and data-driven basically means is we collect a lot of information from our clients. We track outcomes to see if people are getting better or not getting better. Are they going to the hospital? Are they going to the emergency room? And we constantly have to ask the question, are we effective and can we do better? And it's a constant process of collecting data and paying attention to what's going on. And I think one of the fears I certainly have is when you think of a federal program at the community level, how does that impact, your community approach? The thing about CCBHC is it has forced us to pay even closer attention to what's going on with the populations in our communities. Why aren't we serving more veterans? Why is our Hispanic population lower than the population rates comparable to our communities? Why is it that so many of the people that walk through our doors are using tobacco on a daily basis? Why is it that a huge proportion of our children are in foster care? So we have to start asking these questions and orienting our services around how we can be more effective with those populations. So CCBHC does include mobile crisis services. It includes improving access to care and immediate access to care. It requires you to go beyond the four walls and gain access to clients in different places in different ways. There is a huge focus on veterans and active duty service members and family members. There is an increased emphasis on care coordination. So for years, we've always referred out to other systems, but there's an enhanced expectation that you refer out and follow up. Did they actually attend that appointment? If there's a medical issue, did they show up? And if not, how can we keep track and try to help that person get connected with what they need? There is a strong emphasis on relationships with primary care and primary health screening and many other entities, emergency rooms, law enforcement, and it asks you to develop specialized programs to meet the needs. So if you look at the data and some of the things we've seen, we just finished the second quarter of our project. We're learning a lot. But one of the things we did immediately was establish an assertive community treatment program. We were finding, based on our needs assessment, that a lot of the individuals with severe mental illness and legal issues and maybe severe addictions were basically being served by the legal community. And they would go to, the legal, they go to jail for something related to their behavioral health condition, come out, something would happen, and they would be back in shortly. Assertive community treatment really focuses on identifying those people early, trying to catch them upon discharge from the legal institution, from jail, wherever they're coming from, and start services. So we've served 16 clients in 4 months of implementation. We've seen people that were homeless for over a year obtain housing. We've been able to, admit people directly from corrections, which is so important in order for continuity of care. So we really believe in that model. We have established specialized pathways for veterans and MOUs with the VA. We've seen last quarter we served 30 new veterans. Our goal is to serve 100 veterans in year one. We're 3/4 of the way there after 2 quarters, so we're excited about that. Definitely changed and evaluated our admission processes. We admit most of our people same day. Like if you call during a business day, we try to get them in on that same day. For those that do have to wait, our average is around 4 days, which is below the 10-day admission standard. And those are mainly people who choose to wait, who don't want to come in someday and want to schedule an appointment. So that ability to turn around an admission in a short amount of time has implications for access to care. We have started tobacco cessation and tobacco screening activities and are working on tobacco-free initiatives because so many of the people that we treat use tobacco. That's what the data is telling us. And they use it because it's a way to cope with stress and loss and trauma and all the things that our community members have to face. And we believe that treating the whole person and getting them the access to services to improve their overall health will save costs in the long run and improve quality of life. In terms of promising numbers for our project, we've served just under 4,000 people in the first 2 quarters of the project. We're on target to see an increase of 3 to 6% in individuals served, which is really pretty exciting given that we're in the middle of a pandemic and we've had to switch very rapidly to telehealth and televideo and many things non-traditionally. I mentioned earlier that we have served 30 new veterans last quarter, 74 thus far. That number is growing. Referrals are increasing. We've trained over 170 staff members in specialized behavioral health training on how to work with members of the military and understanding military culture. That's been so important for us. 53% of our clients now have an identified primary care provider, which is so important for care coordination and health outcomes. And as mentioned earlier, the ACT program is really showing promises in terms of being to reach at-risk populations. You know, one of the most important things for us is that we've been able to retain employees. We've hired 68 positions, most of which were unfilled in the last 6 months. Our employee retention rate last quarter was 3.9%. We average about 20% annually. So all of these things are very promising. We still have so much work to do, but I believe that this CCBHC model really is mission critical for our state. I've been around through the Osawatomie crisis. I've seen the highs and lows of the system, but we were reaching a breaking point in terms of being able to meet the needs of our community because of the availability. Because really, it really is about workforce and being able to hire and retain quality people to do this work. You can have great systems and programs, but if you don't have great people doing the work, this is a relational business, and we need those folks. As far as the future implications, right now we've done this all through a grant. It's a 2-year grant. Everything is temporary. We believe and want to see the state system go to the prospective payment system that Kyle mentioned. And why that's important, practically speaking, how does that work? What difference does that make? So for us, we shift from focusing our attention on how much service that we deliver. I mean, we're a fee-for-service system currently. We get paid so much per hour of service or per unit of service. That shift focuses from not just how much, but to what type of service and where is that service going to need to be delivered at, and what outcomes are you going to deliver with that service. So it changes how you think about reaching and serving your community and what types of positions and programs does our community need. Not the entire state, not what does Oklahoma, what does Missouri do, what is necessary in Independence, in Coffeyville, in Caney, in Winfield, those places where we know we have people in need. We know that we have high rates of suicide, we have high rates of meth use. We're learning so much about the people we serve just by paying attention to the data, and the CCBHC really pushes us in that direction. So I would just close by saying that I strongly believe in this. I believe it's the future of Kansas, and I believe that it will stabilize a system that has been underfunded for quite some time now, and I believe it will make a tremendous difference in our community. So I strongly support House Bill 2160, and I thank you very much for entertaining it and considering it during this time of pandemic and many other changes. So thank you very much for the opportunity to testify, and I'll answer questions at the appropriate time.
All right, thank you very much, Steve. And I am going to mention to the conferees is that we want to try to keep things around the 4 to 5 minute, because we want to make sure we have plenty of time for questions, and we do have quite a few conferees. So next I have Tim DeWeese, with the Director of the Johnson County Mental Health Center. Welcome to committee.
Thank you, Madam Chair. I appreciate the opportunity to appear before you and the members of the committee. I appreciate the opportunity to present testimony on this bill, which I would consider as a roadmap forward to improving the health and well-being of the entire state. Thanks to bipartisan support and leadership in the U.S. Congress, certified community behavioral health clinics are leading a bold shift to increasing high-quality mental health and addiction treatment, which is making a difference in the lives of thousands of individuals and communities across our nation. The lack of access to timely, high-quality mental health care and addiction treatment is the greatest barrier to a healthier Kansas. It is estimated that more than 250,000 Kansans experience serious psychiatric distress annually. It is estimated that more than 250,000 Kansans, additionally, people living with mental illness who are untreated or more likely to come in contact with law enforcement, which would result in larger numbers of individuals being incarcerated or arrested. Compounding the lack of access is is the fact, compounding the lack of access, is the fact that Kansas has a lower number of individuals that are serving these folks. It has a lower number of behavioral health professionals per capita compared to the rest of the United States. And the shortages are particularly evident in rural areas. However, in recent years, we have seen the lack of behavioral health workforce shortages here in Johnson County due to the implementation of CCBHCs in Missouri and our inability to match those competitive wages for behavioral health care professionals. As Kansas explores the opportunities to implement CCBHCs, initiatives via Medicaid waiver or state plan amendments, it's clear that this designation will put an emphasis on the quality of services that will manifest in these following ways. First, service recipients will receive whole care. Second, recipients will have a better access to service where and when they need those services. Third, service recipients will have access to a comprehensive range of high-quality substance use and mental health services. And finally, service recipients will be provided primary screening and monitoring that might otherwise be missed by acute care settings. In return for this, the CCBHCs receive an enhanced Medicaid payment, as we've discussed, through a monthly or prospective payment system. That rate is specific to the reimbursement that is expected of the demonstrated services. The rate is intended to reimburse CCBHCs their expected cost of care, and the Centers of Medicaid and Medicare Services provides technical assistance to states to how to determine this PPS rate. Finally, the CCBHC model really delivers on the triple aim of healthcare. And what I mean by the triple aim of healthcare is that if you provide access to services and you provide them in a high quality way with positive outcomes, then you see cost containment across all systems of care. That would include cost containment within the mental health system, within the criminal justice system, within the hospital system. Meeting the federal definition of criteria for CCBHCs and receiving that designation will represent a return to community mental health in Kansas and renew the promise that was made with mental health reform in 1990 by providing a comprehensive range of mental health and substance abuse disordered services to vulnerable individuals. Given the increasingly complex and challenging needs of the individuals and the families within our communities, as well as the prevalence of drug and the rise of suicide, it is more important than ever that we are able to have people access the care and services as they need them. Thank you.
Thank you very much, Tim, and then we'll take questions here at the end. Appreciate you being here today.
Thank you.
Next, I have Joan Tammany, the Executive Director of ComCare, Sedgwick County. Welcome to committee, Joan. Are you there, Joan?
I got it.
All right. Sometimes we have to find that unmute button.
I know. I thought I had it down. Well, thank you for allowing me to testify today. I do want to start, though, by thanking the efforts this committee made last year on behalf of the mental health centers. I know you were strong advocates for additional funding, and I know because of COVID that was eliminated, but I just want to acknowledge the work you did on our behalf last year. I'm in favor of this bill, just like everybody else, other conferees today. The needs in our communities are just great. They're greater than our capacity. And this model of service delivery is a critical step forward for us because it assures more timely access to high quality specialty services. We have a long legacy, the CMH system, of serving those with highest need, and have done so through creative problem solving and strong partnerships in our community. But we've also done it with limited resources, and it has resulted in fostering disadvantages to our system of care. Everybody's going to speak to the fact that pay isn't equitable. We have in Sedgwick County and in many other communities in Kansas, a large number of provider agencies and other systems of care that are recruiting our staff away. at higher rates of pay. And I get it. It's a life-changing opportunity for our workforce, but it's also frustrating for the remaining workforce and for those of us that are trying to keep services going. It also disrupts care for our patients because they gain a relationship with that provider, and then the provider leaves and they have to start over with somebody new. And this turnover, of course, impacts outcomes and increases the utilization of more costly options like our emergency departments and law enforcement. And we just know we can do better, and we believe that the Community Behavioral Health Center CCBHC is a solution that's working across the state and the United States, and can work here in Kansas as well. Mental health and addiction treatment, when received in a timely way and delivered by high quality teams, does make a difference in the lives of those we see. But we must continue to promote hope and healing by supporting policy changing, making investments in the critical infrastructure of community mental health centers. You know, we're responsible for serving anyone regardless of their ability to pay, and held to licensing regulations with hefty administrative burden. And we're not complaining about that because the CCBHCs impose a lot of rigid requirements, all geared toward providing better care and better access to services. So at the heart of the CCBHC model is the universal set of requirements around staffing and other things that Steve and Kyle spoke to earlier, with Medicaid payment rates that cover the real cost of delivering these enhanced services. But most importantly for me and everybody else testifying here today is we get the services to those that need it when they need it. So I really look forward to the day when our staff stay with us because we're a robust enough and adequate enough funded system, and patients no longer stop services because their providers have moved on. And we also know that warm handoffs, although well-intended, often don't happen because our patients then and their family members have to navigate a new system of care. So the opportunity to save lives and allow our centers to invest in new evidence-based practices that are prohibitive right now is a real advantage to this new model of care. I'm not going to read everything I wrote, but you know we've done cost avoidance studies for our crisis center since 2015, and we are having the crisis services in the continuum that we have has saved the state and the county greater than $9 million a year, because we can provide a more effective level of service at the crisis center than in the jail or at the hospitals or at the state hospital. But it's all about relationships. It's all about providers and other systems of care working better together. We're proud of the work we do, but we do know we could do better. And in that respect, I speak in favor of CCBHC legislation. Thank you.
Thank you, Joan. I appreciate that. Next, I have Walt Hill, Executive Director of High Plains Mental Health. Welcome to committee, Walt.
Well, good afternoon, Chairman Landwehr and members of the committee. Thank you. Welcome from the Great Plains of Western Kansas, and where we're expecting winter to hit once again. I want to visit a bit about what a CCBHC in Northwest Kansas and our 20 counties would mean. I've worked in mental health here in Kansas since 1978. I've seen a lot of changes, and I've seen a lot of needs. As one of the other conferees said, the needs are great and the resources just are difficult to round up to meet all of those needs. The CCBH model provides an opportunity to meet many of the unmet needs that we struggle with, that the state of Kansas really doesn't have the resources for, that in part enhanced Medicaid prospective payment would offer. It raises the bar from where we are at now with the state CMHC license and configurations, and raises the bar to the kinds of enhanced services that other folks have spoken to. As we have been developing a application for one of the SAMHSA grants in the past few weeks, we've looked really closely at what the needs are in our area to see what the hotspots are of needs in our 19,000 square mile region. One of the biggest areas that we plan to address once we raise that bar are the huge needs for substance use treatment. There really is very little in the way of substance abuse treatment in Northwest Kansas, a little in the way of detox or residential treatment, and particularly huge growing needs around opioid addictions. So we look at a major initiative to raise the bar with increased staffing, a really robust substance use treatment program that includes a full-time addictions psychiatrist to provide what's called medication-assisted treatment. There are many new medications that help people who have addiction and dependency overcome their addiction to alcohol, opioids, meth, to get them through and to their recovery. The other areas that we focus on are health monitoring for all of our patients, similar to the One Care Kansas program that's limited to Medicaid, offering that to a much broader scope of patients who often have multiple physical health problems and often, unfortunately, die early, up to 25 years earlier in life than other people in the population. Veterans in our area have huge needs. They're often much more isolated, being farther away from veterans clinics. Our agriculture community, we're looking at special emphasis to outreach to those communities. As Mr. Denning mentioned, increasing the bar to get patients in quickly. We know that if people have to wait to get in to service, even a few days, often they change their mind, or more unfortunate things happen in their lives too. So we want to be able to respond even more quickly than the current standards now. And there are other underserved populations, particularly the growing Hispanic population in our area, that we want to be able to outreach to those communities, the community of poverty in our area that is growing, and to enhance our ability to deliver mental health first aid training across our region, particularly into the agriculture community, the veterans community, the Hispanic population, and others. So that's what we envision going forward. This will make a difference. I always think it's important to ask, in what way will a piece of policy make a difference? This is what I see, what I envision. Your passage of this would allow for Northwest Kansas, and I sure appreciate the support, the encouragement from the Modernization Committee advocating for this, and as Joan mentioned, also your long and faithful support for the CMHC system in Kansas to help provide the resources. This just will allow an additional partner through additional federal mechanisms to enhance the state's ability to partner with mental health centers by bringing them to the table also. Thank you. I'm glad at your pleasure to answer any questions when you wish. Thanks.
Thank you, Walt. Next, I have Randy Kallstrom with the Wyandotte Behavioral Health Network. Are you there, Randy?
I am. Can you hear me, Madam Chair?
I can, and Representative Wolf Moore was looking forward to maybe setting in on this, and she got called to another meeting, so she did want to let you know that she's definitely interested in watching this project.
Oh, thank you very much. I'll appreciate that. Thank you for the opportunity for being here, Madam Chair, members of the committee. And I started here at the Mental Health Center in 1993, so 3 years after mental health reform was passed in 1990, and it changed the mental health system in the state. I can remember working with children and helping them get out of Osawatomie State Hospital, getting out of Rainbow State Hospital, and they had lived in an institution for many, many years of their childhood, as many as 6-7 years of their childhood. And the same thing was true for adults. And while there have been many good things that have been passed from legislation since then, the Medicaid waiver for severe emotional disturbance, the school mental health pilot, crisis centers. Since 1990, the system as a whole has been pretty stagnant, meaning there's not really been a significant enhancement of the system as a whole for the residents of Kansas since that time. Meanwhile, changes in the role and the procedures at the state hospital in the last few years have placed a greater burden on community mental health centers to treat and keep individuals safe in their local community, but without any additional resources. House Bill 2160 would not only enhance those services for those seeking mental health care and provide greater funding for those services, it would be the first transformational legislation for mental health since mental health reform. As has been discussed by Mr. Denny and others, the expansion of services under a CCBHC would be significant. We would look at the overall health of a person, including primary health screening and the ongoing monitoring of key health indicators, expansion of crisis services, suicide prevention, substance abuse services, as well as the expansion of peer support and family support. Evidence-based practices, such as an ACT team, which is part of our plan in becoming a CCBHC, would create evidence-based targeted programs for the highest need, highest risk clients in our community. And together, these enhancements would lead to a reduction in state hospitalization, bookings into local jails, and incarcerations in the jail prison system. But as has been mentioned, without a well-trained and stable workforce, the mental health system in the state of Kansas will never truly meet the needs of our clients as well as we could. With the last Medicaid rate increase coming 14 years ago and grant funding currently being stagnant at 2008 levels, community mental health centers are unable to keep up with the market rates for the salaries of providers, and we struggle to recruit and retain staff. Wyandotte Mental Health Center is literally a river away from 4 CCBHCs in Kansas City, Missouri. They have all significantly increased their salary structures to the point of paying $10,000 to $15,000 more for the same level of provider than what we are able to pay. We are now far behind in salaries compared to schools and managed care organizations as well. Yet every day, we are asking our staff to work with the most challenging clients who are at the highest risk for hospitalization, dying from suicide, being booked into jail, and facing the daunting determinants of health, including homelessness. HB 2160 provides an opportunity to enhance those services for those people in Kansas who are needing mental health care and treatment. Simply said, it is the best opportunity in a generation to transform the system of care for some of our most vulnerable citizens. I strongly encourage you to pass House Bill 2160 and look forward to your questions at the appropriate time. Thank you very much.
Thank you very much, Randy. And Representative Wolf Moore did just appear into the room, so she caught most of your testimony. Next, I have Amy Campbell with the Kansas Mental Health Coalition. Welcome, Amy.
Thank you, Madam Chair. My name is Amy Campbell. I work for the Kansas Mental Health Coalition. The coalition is a roundtable organization of multiple groups, provider associations. We have participants that are inpatient hospitals. We have psychologists, psychiatrists, social workers, all of the community mental health centers, and numerous advocacy organizations and consumer groups. We are a broad spectrum organization that meets once a month as a roundtable to develop consensus on issues that we all care about. The creation of CCBHCs fits very neatly into the recommendations, as you have heard, from the Special Committee on Mental Health Modernization and Reform. It also fills major gaps in the continuum of care as highlighted in the 2018 and 2019 Legislative Mental Health Task Force reports. My testimony talks about how it fills the gaps in the continuum of care, but I think that's been covered pretty well by previous conferees. And they have also talked about the fact that this does a lot in moving towards resolving the workforce shortage that was also highlighted in those task force reports. Because of the broad reform offered by the CCBHC's model and its ability to meet these very serious needs for our behavioral health system in Kansas, the Kansas Mental Health Coalition supports this legislation. I would also comment that when people talk about this, it might be easier for you to understand it in thinking of the fact that the federally qualified health centers that used to be called safety net clinics are under kind of a similar certification model and access the enhanced service spectrum and reimbursement model when that was passed. With that, Madam Chair, I'd be happy to stand for questions.
All right, thank you. We're going to go through all of our conferees, and then we'll come back for questions. Committee, we do have written only from the Kansas Association of Addiction Professionals and from Sean Gatewood with the Can Care Advocates Network. Did I miss any other proponents? All right, seeing none, now I have Sarah Fertig. I believe that you're here with us from KDHE, the State Medicaid Director.
Yes, I am. Can you hear me, Madam Chair?
Yes, Sarah.
Let me get my video going. There we go. Thank you, Madam Chair. And thank you, committee. Good to be here today, albeit remotely. KDHE is neutral on HB 2160. In terms of the policy question of whether or not Kansas should pursue the CCBHC model, we're neutral on that. However, we do have some concerns about the time frame contemplated by this bill, and as well as the effect that this could potentially have on the financial side of Medicaid. I would draw the committee's attention to our written testimony, which fleshes out some of these details a little bit more. In the interest of time, Madam Chair, I'll keep my comments pretty high level. We think that in order to responsibly implement a program such as this, it wouldn't be possible for us to do it by July 1, 2021, simply because there's a lot of details that we would have to iron out. And as some of the conferees noted, the CCBHC model was discussed during the Mental Health Modernization and Reform Committee that met during the interim. And there were discussions about it. However, they're usually pretty high level, and we never really got into the details about what would be required to stand this up in Kansas. So on our written testimony, we include some bullet points of some of the details that we would have to iron out before this could go live. For one thing, we would need to draft either a Medicaid state plan amendment or an 1115 waiver amendment. With the transition at the federal level, CMS has advised us that they would ideally want about 18 months to do either of those for a policy shift of this size, because they would have a lot of work to do on their end, and they're still getting leadership in place. So CMS has respectfully asked that if we need an 1115 waiver amendment or a substantial state plan amendment, that we give them up to 18 months to review and approve that. So that's one thing that we would need to do in order for this to take effect. We would also need to assess the extent to which the financial side of this would affect our 1115 waiver budget neutrality. I'd be happy to answer any questions on that if you like, but generally the budget neutrality refers to the total amount of money that we're allowed to spend on the Can Care program. And if it looks like we might exceed that, then we need to ask for special permission from CMS, either through an 1115 waiver amendment, or we might have to cut costs in other areas of the Can Care program. We assume that lawmakers would want to know if the CCBHC program is working. So we would need some time to design an evaluation plan and make sure that we have the data necessary so that we could answer that question for you. And in terms of setting up the PPS rate, that's the prospective payment system rate, that's pretty complex. Luckily, we do have experience doing that because that's how we pay our federally qualified health clinics. Like GraceMed here in Topeka, we do pay a PPS rate for them. But getting to that PPS rate is a little bit tricky because it depends on each facility's individual costs and when it comes to providing services for the Medicaid population. So we would need to work hand in hand with the CMHCs to get that information, make sure that it includes only allowable costs, and finally get down to a facility-specific PPS rate. And other states that have set up this CCBHC model, they've done that with an extensive amount of technical assistance to the CMHCs who have applied. And that's something that would take us quite a bit of time. I looked into attaching some more information about the PPS rules for CCBHCs to our testimony. The most condensed version I could find was a 29-page document that referred to 2 larger manuals and a bunch of other federal regulations. So I did not do that to you, but rest assured, establishing a PPS rate is a little bit more difficult than it might sound. And we would also need to make some changes to our Medicaid claims payment system, which is a very complex IT system. And we are currently in the middle of a major overhaul of our claims payment system, which is about 20 years old. It's antiquated, and we're trying to modernize it and put it into a more user-friendly modular format. And we're under some pretty tight CMS guideline or deadlines to get that done. So ideally, we wouldn't establish those IT changes until July of 2022 if we want to stay on our deadlines with CMS for that. So largely, Madam Chair, our concern with this bill is on subsection E, which requires us to stand everything up by July 1, 2021. And so if the committee decides that you wish to move this bill forward, we would respectfully ask for some more time to accomplish that. Ideally about 18 months lead time before we could go live. And I'd be happy to stand for questions at the appropriate time.
Thank you very much, Sarah. Committee, then I have written only testimony from Secretary Howards with KDADS. Was there anyone else that had thought they were scheduled and we have not called upon them? All right. We're going to go ahead and open things up for questions. I've got a couple of rather quick ones. Kyle Kessler, a couple for you. If I recall correctly and understand, one of the reasons that we've heard that it's a concern when we have states surrounding us with CCBHCs is because there is a higher reimbursement rate, which is what translates into higher salaries. Is that correct?
That's correct.
And that higher reimbursement rate is on just some of the services or all of the services of a CMHC?
It would, just the Medicaid eligible services.
Okay.
So that's one piece of it, and then it's based on your costs. So in theory, the higher the fiscal note might be, it would mean that you're underfunding the system by that much.
Right, because right now we don't reimburse at cost. The only ones that probably get that would be our FQHCs. Would that be correct?
To my knowledge.
Okay, we just heard from KDHE, Medicaid Director, that it would take them at, probably at least 18 months, et cetera. Do you have any idea how it is that the federal government, who's just offered these grants, how long it would take for those 5 to get up? Because we don't have to go through the 1115 waiver process.
Steve, if he's still on, could tell you that, but that's part of this idea. They were thinking that they wouldn't even be able to be up and going on a PPS until probably July or more likely January. So I could see moving it back to January 1 possibly, but those who are just starting on that were far enough away.
Okay, thank you. That's all I have for you, Kyle. And then I do have a question for Steve, if you're still there.
Yes, I'm here.
Okay, Steve, now are you guys up and running as a CCBHC? Or are you still in the final stages? Where are you at?
Well, I would use the term lookalike. So we are not a certified CCBHC. That ultimately can only be done by KDADS as a result of this bill or something similar. We have attested to all of the elements required to be a CCBHC. So I would say we are close. Now there are still some things we're rolling out in terms of outcome measures and tracking things in our electronic health record. There are still some services and vacant positions that we're working on, but we've attested to that we are a CCBHC based on the 6 major service areas as specified by SAMHSA. So yes, with it's a work, but it's also a work in progress.
Okay, so Steve, could you provide us, we don't have to go over these today, but if you could provide us, what are the 9 core outcomes that you're required to track? And also, what are the continuous quality improvement measures? I think that would be of interest to our committee, if you wouldn't mind sending those to us.
Sure.
All right, I appreciate that. Committee, further questions? I have Representative Epley.
Thank you, Madam Chair. And this is for Kyle, if he's handy. Looks like he is. So, Kyle, is there an arbitrary amount for each CCBHC, or does it vary? And I'm not quite sure I understand that. And then the other thing is, I realize this is breaking news, but is some predetermined geographic location for some of these been determined, or is that still to be determined? Thank you, Madam Chair.
Yeah, thank you, Representative. And those are both excellent questions. And so the cost part of it would depend on if the cost of living or the salary expectations from Southeast Kansas would be different from Johnson County, different from Waukene or Hayes. And so Steve could also probably help talk about how they came up with their prospective payment system, which they would probably look at a monthly reimbursement rate. So that would vary across the state, just like it would with the FQHCs from Southeast Kansas to Western Kansas to Wichita. Then the second one, as far as the geographic location, it has probably more to do with the services that are currently provided by the CMHCs. So if I could flip a switch and have all 26 able to provide all the services and to be able to do the billing appropriately, then that would be great. But that's not reality. For the quick example I would give is that the CCBHC grants that were done, about 10 of the 26 CMHC applied, believing that, yeah, we can get up and going with this pretty easily. And I know of at least 2 or 3 others that will do that this time. So we're probably looking at a good couple years of implementing. So no predetermined geographic location, but the ones I know of that are interested are all across the state, from Western Kansas, Northeast Kansas, et cetera.
You got another one?
Thank you, Madam Chair. For
Then
Sarah,
that's your limit.
I'm done. Sarah Fertig, can you hear me, Sarah?
Yes.
So in your written testimony, and I read it, I just a little background information on the when you thought was a reasonable timeline for implementation from your standpoint. You thought that this coming July was a little soon. You think a year from this July is more reasonable with your background?
Definitely more reasonable. We think July 1, 2022 is probably the earliest we could responsibly stand up a program like this.
Well, you think that's feasible then?
Yes, we think we can do it by July 2022.
Thank you very much.
Representative Blacks.
Thank you, Madam Chair, and my question is for Steve Denny.
Yes, sir.
I'll call your neighbor since you only live about 3/4 mile from me.
I don't think your mic's on, Representative.
It is now. I'll call you neighbor since you're just about 3/4 mile, and I really applaud Fort County for having the vision to apply for this grant to get a test mode out there and see this working. And being a veteran myself, I certainly appreciate all the veteran that you're serving. And I guess my I'll have a confession. Fort County and Director Greg Hennon, as well as Steve, have actually turned my opinion around of the value of mental health to the positive, I must say. And certainly since I've been involved in and watched our operations, seeing what they have gotten done and the innovation there, it's been a change of heart for me, and I appreciate that. And I guess my question to you, does Fort County get with the MOU from VA, which Parsons is fairly close, does Fort County get reimbursed for that, or is that part of the grant process?
Well, it's a little bit of both. So we have an agreement with the VA Optum network, which reimburses for some VA services, such as counseling and medications and things like that. The MOU is basically just a care coordination agreement saying that we will accept referrals and provide care at a certain level to veterans. And then those services would then be reimbursed through the cost-based model under the PPS system. So right now we're using grant funds to essentially cover those services and build those services. And the VA would cover a portion of it, but not all of them, particularly the case management and care coordination type activities, because there aren't necessarily codes that are reimbursable for that through the VA. We currently have one VA with the Eastern Kansas VA, and we have almost one with Robert Dole. We're still working on some final signatures on that. So I don't know if that answers your question, but kind of yes and no. It partially does, but part of it will be covered under the cost-based system we've been talking about.
Thank you for that. Thank you, Madam Chair. See you at church Sunday, Steve.
Okay, thank you.
Representative Kelly.
Thank you, Madam Chair. And my question is for Steve, too. Steve, I know that through you and Greg, I've heard about the competition in Oklahoma. If Kansas will passes this bill and it happens, will that solve most of your issues going with the state of Oklahoma for your employee loss and the other things that come up?
It'll stabilize it. I don't know if I'd use the term solve, but it'll certainly stabilize it. I mean, what we've encountered is entry-level positions paying at, someone said 10 earlier, we've seen, before we had the grant, $30,000 higher than our entry-level positions. So basically, payment at management experience level for people walking, it was just so beyond what we could do. We'll be able to match and get closer and closer to that. And I really think our system and our work environments have a lot to offer in Kansas. So maybe we're not 100% matched, but we certainly are much more competitive. And for those folks who live on border states, I think it becomes, we become a much more viable option. And the local people, you know, that are driving to Oklahoma, I think will be that much more appealing to those who live in Kansas. So I think it will help significantly. It has helped because we've been able to retain and hire a number of positions that were vacant that I think maybe we would not have if not for this grant.
Outside of being able to solve the workforce shortage in this area, it's going to take us a while to figure out how it is that we can have enough workers out there to serve. Representative Reese.
Thank you, Madam Chair. My question is also for Steve Denny. Steve, can you talk more about the assertive community treatment programming? Is that an ACT team?
Yes, it is an ACT team. We developed that. That was one of the components in the grant that you're supposed to provide intensive community-based services, and that's one of the programs mentioned. We researched the model and thought it made a lot of sense. And we've developed two teams, one in Cowley County and one in Montgomery County, still building that and growing that, but it involves case managers, a dedicated therapist, a nurse. You're supposed to have a prescriber, but in rural America, we're having to kind of share some of those roles. It's because of availability of staff, but it really is intensive focus. There's peer support component to it as well, but it's evidence-based practice. We meet with Case Western Reserve University. We have to meet fidelity to their model and have a lot of things lined up in order to deliver that. But practically speaking, it's very intensive services to a small group of people that otherwise are not engaged or being managed by either the state hospital system or the legal system. It really does offer a lot of benefits, and it's one of the models mentioned in the CCBHC criteria and kind of founding documents.
And is the service primarily provided in the community or in an office?
It's designed to be developed in the community. Obviously, COVID and the pandemic have created challenges, so some of that is done televideo, particularly the medication part. But no, it's community-based. We have folks going into the jail, doing intakes in the jail so that we have a smooth admission process. It's wherever they're at, and it's also whenever the service is needed. So we have to integrate with our crisis services. So if an ACT client calls and says, I have a housing crisis or a relational crisis, there's certain procedures that have to be followed there. So it's very comprehensive.
Madam Chair, can I ask a follow-up question? And is law enforcement involved in any kind of way?
Yes, they are. Obviously, the Department of Corrections and jail administrators. We've also been involved with correctional officers who've made referrals. And yeah, we marketed it to law enforcement, police chiefs, sheriffs, not just ACT, but the entire model, because part of CCBHC is establishing MOUs with emergency rooms and law enforcement organizations. So those conversations go different in every community, but that's a part of it where we establish referral expectations and make sure they know about that service and program.
Thank you so much.
You're welcome. Thank you.
Thank you, Madam Chair.
Committee, are there further questions? Now, Kyle, I got one for you. Now, and it might actually go to Steve, so either one of you might answer this here, is, with the talk of the original legislation was for us to, not knowing we would get any further grant programs, which now we just found out we're going to get 5 of them, what is your ideas or of the testimony that you heard from KDHE on the timeline?
On the timeline, I knew that we were being aggressive with July 1, 2021. I felt like that was too much about the time we wrote it. But in terms of an additional year out, I for sure believe that moving it back to January 1, 2022 would be fine. But it could be that in visiting with some of our members that we could get it further back and be okay if they're committed to that and that becomes statute.
Okay. Committee, are there any further questions? Thank you, Kyle.
Thank you, Madam Chair.
All right, seeing none, that closes the hearing on House Bill 2160. And if you've looked at the agenda for next week, it is the intentions of this committee to work House Bill 2160. So if you've got ideas, you've got recommendations, or you've got amendments, and you wouldn't mind sharing those with me in advance, we'd appreciate it. The CCBHC legislation actually came out of the mental health modernization. We've talked about it now for a few years, actually. And it was a highly strong recommendation from that committee. So, committee, we are adjourned till Monday at 1:30.